Kia ora tātou, everybody. Bruce Harrell's my name. Welcome to this webinar on sepsis, how not to miss it in primary care. Our guest tonight is Paul Huggan. He's in acute medicine and an ID physician at Waikato Hospital. So welcome, Paul.
Kia ora tātou, kia ora Bruce, Maori ora. Thank you so much for inviting me to talk to you tonight. Wherever you are in New Zealand, e mihi ana kia koutou, ko Paul Huggan tōku ingoa, no ko te rana ahau, ko Ilden te maunga, ko Tui te awa, e haere au ki Aotearoa I rua mano matahi ki tōku hoa wahine, ko mana ia, ko te atanga maha ki rawa ko Arongo Whakata ia. E noho ana ahau ki Whaingaroa. I'm speaking to you from not so sunny Raglan this evening, and I'm just so pleased to be talking to an audience about a topic which has occupied most of my sort of spare hours as a medical professional in the last, certainly in the last 10 years. And the way I'd like to address this tonight, I'd like to tell you, first of all, why this keeps me awake at night and what I'm doing to try and improve, what me and other people are doing around the country to try and improve recognition and response to sepsis, but also to recognize what a burden of disease, what a burden it places on our populations and which populations are at special risk. And the way I'd like to do this is to just introduce a little bit of the work that I do. I'm going to ask you for money, and I'm going to talk a little bit about my research. I'm going to talk a little bit about the epidemiology of what sepsis in the Waikato region and why that's led to deeper questions about why particular groups of people are at risk of this condition. From there, I have to tackle the rather dry topic of the clinical tools that we've put together to try and assist with decision making. And throughout that, I'd like to recognize the enormous bank of knowledge and skill and experience that's in the webinar tonight. So I'm not going to try and teach you anything that you don't already know, probably. I would like to show you how we've tried to codify knowledge so that it's usable and so that you can and maybe provide some tricks of the trade and some critical language that might make some management of people across the spectrum of acute care a little bit easier day to day. And one of the things I was asked to do is to give people knowledge and skills they can use tomorrow. So that's what the middle focus of the talk is. And then towards the end, I want to talk a little bit about sort of advocacy work and why advocacy and planning and investment are important for any condition, but sepsis in particular, and what the Trust has been doing to try and partner with people here nationally and internationally to promote the kaupapa of sepsis in the interest of improving population health. So I'll take them a minute to let my heart rate come down a little bit, and I'll get my slides up so that we can start talking to those. That's fantastic. So yes, that's who I am, and slide one. So later on we'll be hearing from Reece, and this is the kind of the picture of sepsis that I think we're all scared of. There's a fit, well, young person fixing their car one day and enjoying the company of their whānau, and in hospital, confused, sleepy, hypertensive, and rather ill the following day. And Reece's story is available in full on the Sepsis Trust website, and we've been putting a lot of work into this in the last sort of 6 or 7 years of trying to collect stories together that people can use to learn about what it feels like to have sepsis and what people other than doctors and nurses and other health professionals worry about, and what it looks like to when your loved one has sepsis. And seeing this problem from that point of view has been very useful to me to help understand how to tackle it. I did say I would ask you for cash. So it's World Sepsis Day in September the 13th. There's no budget for sepsis nationally. There's no other organization in the country that's trying to work to improve resources for primary care, clinical tools for healthcare professionals, that's writing and delivering quality improvement programs in secondary and tertiary hospitals, that's trying to attract the attention of government and MPs to this problem. And we are doing what we can to bring attention to this. And part of that is inviting people to have a little bit of fun and to give a little bit of cash. So if you feel up to it, and you have $20 to spare, if you visit sepsis.raisley.com or donate on the Trust website, we'd gratefully receive any donations that you feel you can throw our way. And all of that money would go to maintaining the support services that we do provide. We've got 5-day-a-week access to specialist support nurses. We run a Facebook support group, and we are in the process of organising small grants for sepsis research. So with the Step for Sepsis entity, if you want to get involved, is taking as many steps as you like to publicise on your social media accounts between the 1st and the 13th of September, and getting involved in social media and drawing attention to this problem. Have a look at the website and use the resources that are there. So who am I? So I trained in medicine in the UK. I met my wife in Dumfriesshire, and 3 years later, wanting a life less ordinary, I thought I'd come to New Zealand to be an anaesthetist. And I slithered to a halt with a career in general and infectious disease medicine about 8 years later. And I started to train in infectious diseases in Christchurch, and then later moved to Singapore, where I worked for almost 5 years as in the National University Hospital there. And I think because I've always been committed to acute medicine and infectious diseases, I've been very interested in the diseases that sit at the overlap between those two specialties, and sepsis is very much in that space, because as an infectious disease physician, I never see people in their first 12 or 24 hours of sepsis. As an acute medicine physician, sometimes that's all that I see. And so it's very, very useful to have an interest in sepsis, because it's really been at least 30% of our day-to-day medical take is people presenting with infection and organ failure. So as a new consultant to Waikato Hospital, there was only 2 of us, and there was no department. And one of the things that we decided to do to try and justify investment into infectious diseases was to try and count the number of people with infection and sepsis specifically that were coming to Waikato Hospital. I won't go into the fine detail here, except to say that we used coding, and we took a lot of codes for bacterial infection, and we mashed them together with codes for organ failure. And that's been the traditional way that people have tried to study the epidemiology of sepsis, because it allows you to use large data sets to try and look at data over time. And there's no other really good way of doing this with the data that we have. So we used that to provide this data. So this is back through to about 2007 to 2012. And what we found, probably shouldn't have been too much of a surprise, but still, was that people living in the 5th quintile of socioeconomic deprivation were quite significantly increased risk of an incident sepsis event. And that independently of that, because these figures are all controlling for everything else in multivariable analysis, Maori being of Maori ethnicity gave you an odds of 3.2 times the risk of sepsis compared with the other people in the study. The other hint that we got was that perhaps the incidence of this condition was increasing over time. And I remember looking at this at the time and thinking, well, what's all that about? And I think that kind of questioning sort of driven everything else, because I could easily just have put this aside and been very happy with the business case that we got through, because we've now a department of 4 or 5 consultants, depending on which way you look at us, and the registrar and the pharmacist and so on. But actually particularly the ethnicity finding, I felt was a bit unusual and needed to be explained. But how naive I was at that time. So what I was saying to Bruce earlier on was I wanted to put the real message of this talk at the very front, because this is really what a lot of thinking and reading and research has kind of led to. If you're going to recognize sepsis and why it is what it is and why it's a bit difficult to recognize, you have to sort of reframe how you think about it. There's been a lot of efforts in the not so recent past to try and provide an accurate definition of what sepsis is. And for many, many years, people have tried to drive this idea that it's an immune response that's going wrong. And that there's definitely a lot of truth to that, but it doesn't work as a model of disease. It's the current definition in what's called the Sepsis 3 definition of sepsis is plainly wrong. It's very difficult to talk about with between and clinicians, and certainly with patients, the people that we treat. So the definition of sepsis that we've got at the moment is really not fit for purpose. And to me, it doesn't really describe the disease. So if you think back to how we've always talked about sepsis, what did we actually tell people had gone wrong when they had sepsis? Well, there's this historical term called septicemia, so of the blood. And there's and people in Scotland and actually New Zealand tend to talk about blood poisoning due to infection. And in many ways, just using that plain language, it makes a lot of sense. So I'll show you a few slides further on, which suggest that sepsis actually, the target organ of sepsis, the organ that's propagating and amplifying the sepsis response, is actually the vascular endothelium. And I come back to this earlier finding in the epidemiology, which showed that poverty and ethnicity are risk factors for sepsis, which is organ failure in the setting of infection. So why would that be? Well, under normal conditions, your endothelium is in what's called a resting state, and your immune system should really be in a resting state. It should not be responding to very much. It should not be trying to damage anything. It shouldn't be activated within our tissues. In that state, the vascular endothelium is inactivated and non-inflammatory. And but what's become clear in chronic disease research is that stress and poverty and smoking and chronic disease and almost any other chronic condition or stress that you can think of actually transitions the immune system and the vascular endothelium to what we think of as an activated or pro-inflammatory state. And in the endothelium, that's increased adherence of neutrophils, that's increased loss of the protein glycocalyx that sits in the inside of all of our blood vessels. It leads to increased expression of adhesion proteins and increased migration of neutrophils into tissue. And so chronic disease states and stress, familial stress, financial stress, and social stress are actually associated with this activation of the endothelium. So what does that look like? Well, this is a paper. This shows all of the various changes between a resting and an activated endothelial monolayer. And infection meets inflammation meets endothelium. So what I think happens in sepsis is that you get an infection in any particular organ of the body, lungs, bladder, primary bloodstream infection, gut, appendicitis, whatever it is, and poisons from that infection or the bacteria itself make it into the bloodstream, meet an activated endothelium, and then the sepsis syndrome is expressed through dysfunction of that damaged endothelium. So what do we see when we're in the hospital looking at people with sepsis? We see wet lungs, damaged kidneys, liver failure, confusion, vascular collapse, and muscle wasting. So on this recovery side of sepsis, muscle wasting and brain failure are the two things that people complain of, which are specific to having had a sepsis event. So you can treat people with antibiotics and they'll recover reasonably well. But in clinic, they'll very often say, I just can't think very well and I feel so weak. And we know from research in the surgical literature that early on in the sepsis process, there's actually quite considerable apoptosis of striated muscle and myocytes. And so people literally lose muscle strength in the early phases of sepsis events. And this whole thing is orchestrated through the amplifier, which is the vascular endothelium, which invests all of our organs. We tend to forget that the blood supply is not the palpable carotids and the aorta and the ilex and everything else. It's actually every single tissue is completely invested with an endothelial monolayer through which all of the oxygen, nutrients, and immune proteins and cells must travel to manage maintain human tissue. So that's the model that I've carried around with sepsis now for at least a couple of years, and which I've enjoyed talking to Bruce about, and which I shared at the Goodfellow symposium. So what support is there for this idea that an activated endothelium is actually underlying this high prevalence or this incidence sepsis that we see in hospitals. Well, let me just show you a couple of slides which talk to work that's been done in the States on this. So there's two slides here, and actually the bottom slide there in red is the map of the proportion of people in any given state in the United States who've been told that they have had a stroke. And what you can see is this kind of, I think they call it the beltway states in the southeast of the United States, much higher incidence than in the west and the northwest of the same country. And if you look at the blue above, it's a very, very similar pattern in regional variation in sepsis deaths. And this was something which caught the attention of researchers working on something called the regards cohort. So that was a study that aimed to look at regional variation in stroke in the United States. I'll just talk to you about the regards cohort for a minute because it's important to understand how it was set up. So it was a prospectively maintained life course study where they looked at, they recruited individuals to the study, and then they found everything out about them: smoking history, CRP levels, cystatin C levels, alcohol drinking, you name it, quality of life surveys, one of these very clever long-term follow-up studies. And in the regards cohort, they then looked at hospitalizations for stroke, and there's an entire literature on what they discovered about underlying risk factors for stroke. But simply by switching it around a bit and looking for sepsis admissions, they were basically able to show that exactly the same morbidities that increased stroke risk, chronic lung disease, age, artery disease, male sex, tobacco use, previous stroke, atrial fibrillation, coronary artery disease, were predicting incident admissions for sepsis. And so I guess the message there for primary care is that is the people you're seeing every day with significant comorbidity are actually very at risk of incident admissions with stroke. So that's all the elderly with compound risk factors of coronary artery disease, diabetes, hypertension, and who smoke. And on the upper right-hand side of this slide, you can see the if you assign a weighted score to each of these risk factors, and then you look at the rate of sepsis admissions over time for any given score, you can see that people with lots of comorbidity have lots of sepsis. And so, in a sense, we are looking at a blood-borne disease because the thing that unites all of these risk factors is chronic damage to the vascular endothelium. So I come back to inequity, and I used to leave this out to the end of the talk because it's a little bit uncomfortable and it's not something I was entirely sure about how to talk about in the New Zealand context, and which is quite confronting. But as I said to you, in the Waikato where I work, you've got something like a 3 to 8 times the risk of sepsis identifying as Māori versus not identifying as Māori. And you can see that risk increases steeply and significantly from about the 4th decade of life, such that in your 50s and 60s, there's really two populations. There's one at risk of sepsis and there's one that really isn't. And the one that is at risk is Māori by and large, and the one that isn't is not Māori. And again, quite confronting and difficult to understand. But to me, it's the end of the blood poisoning, or the sepsis as a disease of the vascular endothelium, actually explains a lot of this, and this is why. So these are not my words. This is work that's been done by Jessica Brinkworth, and it's been published in an anthropological journal. And Jessica looked at rates of sepsis in every country which has experienced, which describes sepsis rates in indigenous populations, where that country or that population have experienced European colonization. So we're talking about First Nations people in Canada. We're talking about Latin American Indians in South America. We're talking about indigenous Americans in the US, and we're talking about Aboriginal Australians and Maori in New Zealand. And I'm sure this is true for any other population that's gone through the stresses of European colonization. Sepsis burden is disproportionately carried by Black, Indigenous, and people of colour in all countries. This is not explained by inherent genetic factors because humans cannot be sorted into inherent genetic groups. Rather, social factors, economic marginalisation, and residential segregation contribute to wealth inequity and have a profound impact on sepsis risk by fostering living conditions which promote epidemic and close contact infectious diseases, whilst also restricting access to preventive care and perpetuating social adversity. And you'll have to take my word for that this idea is now being translated into programs of research into what are being called syndemics. That is, epidemics of non-infectious diseases, such as the risks which I showed you for sepsis, and contributing to epidemics of infectious diseases, and the two making each other worse. So a syndemic is basically two epidemics which coincide and are cause morbidity that is greater than the sum of their two parts. And certainly get the sense with rates of serious bacterial infection in the Waikato that ethnicity and the effects of chronic social adversity are actually what's driving a lot of what we're seeing, in addition to chronic morbidity. We can talk about that more at the end of the talk. But again, confronting, looking around the Waikato and reading about the Waikato Wars, it's not difficult to spot the relics of the tohu, if you like, of colonization where I live. And we live with these statistics every day, and you'll be seeing this every day in your clinics. It's not really a huge surprise that there's a marginalized population who suffer the effects of infection and express it through presentations with sepsis. And here, just to kind of try and unite all these ideas together, if you're exposed to infection and to deprivation and the morbidities which make sepsis more likely, and if those infections meet an activated and damaged endothelium, you will biologically express that through a sepsis phenotype more often than you just simply recover from infection. And I think that's why we're seeing the burden of sepsis that we see in our hospitals in the region where I work. So this isn't about all of that as much as it's about what can be done in primary care to recognize sepsis. So this is how we conceptualize trying to mitigate or reduce harm due to sepsis. Well, of course, everything starts with reducing risk of infectious disease, and we support everything that that we're all doing to promote programs of sanitation, vaccination, hygiene, treatment of school sores, decolonization of staphylococcus. People with boils will help occasionally. Everything that we do to make people healthy will improve population health, and ergo should reduce risk of sepsis. We are sitting with shockingly low levels of community awareness. So we go to the field days every year, and every year roughly 50% of a educated, predominantly Pākehā audience at field days have heard of the word sepsis. The other 50% do not recognize it, and of them, about 80% recognize some of the alternate words like blood poisoning and septicemia. So we really don't have a population that are as aware of sepsis as they are of cancer, stroke, and heart disease. And so there's a lot of work to do there. I've talked to you a little bit about who groups would be who are at risk. We can do a lot with people who are at risk of sepsis to educate them about key symptoms and signs, and I'll talk about that in a minute. This talk is all about provider awareness, and where I work, we've tried very hard to make sure that when people are admitted to hospital, they meet clinicians who know what they're doing, and they're managed by services who know how to handle a complex infectious disease and discharge somebody with sepsis with some knowledge about what's gone wrong. And of course, we should measure outcomes, but that comes later. So I was asked to talk about how to recognize sepsis. So I was quite pleased when I looked into this for the Goodfellow talk to find that recognize entered the English language through Scots via Old French, via Latin. And there's two aspects to the meaning of recognize. The first is the identification of something having encountered it before. And the second is acknowledging the existence or validity of something. So I recognize that this is a thing, or I recognize that heart attacks are common. So recognizing that a thing exists is also a legal construct, and it's the act of seeing and acknowledging something that you've seen before. Within that first definition, there's a personal definition which relates to an individual's ability to spot something from appearance or character. there's also a machine definition, which speaks to a machine or an algorithm's ability to automatically identify and respond to a trigger. So that's how to define, recognize. So how can we recognize sepsis in data? So I'm going to talk to you about this just a little bit because it's quite important for what comes later. So how do we conceptualize sepsis within your practice? So the 96%, I think, of all antibiotic prescribing in the country is done in primary care, which means that the burden of infectious disease is in primary care. And if you think about that as a pyramid, the vast majority of people who present with infectious diseases in primary care will not proceed to sepsis. But some will. And conceptualizing that in data, you've got people who, I guess, have infection who need to go to hospital. And then there's people who are in hospital who have organ failure. And then it's that group, the top of the pyramid, if you like, in hospital with organ failure that we define as having sepsis in our work. And of course, with collection of organ failure over time, your risk of death increases. So there are lots of different infections, and this bamboozles people because there's meningitis foundation, and there's people who work with pneumonia, and there's people who work with skin and soft tissue infection. So for any, there are lots of different individual infections. You have to look at all them. And what are they? Well, actually, the vast majority of sepsis cases where we can identify a pathogen are caused by about 8 different bugs, like Staph aureus, group A and B and C, Streptococcus, the pneumococcus, E. coli, and Klebsiella pneumonia. That's probably about 80% of all sepsis where we can identify a pathogen. So it's not a large number of organisms which can and conditions which lead to sepsis. That's one thing to recognize. So if we start with that kind of yellow line, the level, how many people are in hospital with an infection, regardless of any other diagnosis, the answer is 24% of people who are hospitalized are given a diagnosis of an infection that would usually need an antibiotic for treatment. And this is work that we did for the New Zealand Medical Journal in 2021. So that's 174,500 people in hospital in I think this was 2018, had to have an antibiotic for a diagnosed infectious disease. So how many of them, what proportion of the hospitalized population have sepsis? Well, this is a much harder question to answer because for all definitions of sepsis, you've got problems with sensitivity and specificity. So we constructed the most restrictive definition of sepsis that we could think of, which was a primary code for infectious disease as the diagnosis which has driven the entire hospitalization in the primary coding position, coupled with an organ failure at any stage of the admission to hospital. And our assumption in data was that represented sepsis, and in our audits that's true about 85% of the time. Why am I even saying this? Well, because when we looked nationally at the number of people who met that definition, it's a much smaller number of people. So about 0.3% of hospitalizations are with sepsis. We think that's an underestimate by a factor of about 5. So we think about the truer number based on studies in Sweden and other places in Europe is probably a 1.5 to 2% of the population of the hospitalized population are in hospital with sepsis. So I think it's about a 1% number, which if you think about the number of people hospitalized every year, excluding COVID and all the rest of it, is a lot of people. So what I wanted to go on to, so the reason I'm sharing this is that sepsis is a big deal. There's lots of it, and it is an issue in primary care, and you've got to weed out people at risk of sepsis amongst all of the other infections that you see. So acknowledge that as a huge challenge. What do we know about how people travel through the acute care system to hospital with infections? Well, we asked the question, how do people who meet our definition of sepsis arrive at hospital? And the answer is 3/4 arrive by ambulance. So the majority of the sepsis cases we deal with have originated in the community, and the majority of them have used the ambulance system to come to hospital. Looking at this data again, I don't know what proportion of these patients had that ambulance called by a primary care doctor or nurse. And that's an omission in the data that we collect. And I simply don't know the answer to that. I couldn't find it out in time for this talk. But at least in the hospital practice, I know that 3/4 of people are being brought from an acute care environment or their own home by an ambulance crew. But how do other patients flow through the primary and urgent care system? And this was, I forget the name of the author of this article, but they presented at the Goodfellow Symposium, and I found this out there. There's quite a big difference in the number of people you'll see with infection depending on where you work in primary care. And obviously this is intuitive, but it needed this talk and this paper for me to realize this. This is Australian data in Queensland looking at the proportion of people presenting to after hours general practice or urgent care or emergency department, depending on their the nature of their presentation. And this is really looking at the where people choose to present based on underlying condition, given the availability of after hours general practice, urgent care, and emergency departments in the same region. So in a sense, it's a study of where people are choosing to go given any particular condition. And what you can see is that on a Sunday in Queensland, about 1/3 of all presentations to any community or ED facility are for infection. But they're partitioned into 13% in ED and about half in urgent care and after hours general practice. So I don't know what the normal pattern of work in general practice looks like day to day, but out of hours, primary care services in Queensland are, I'm assuming that this is roughly true for New Zealand as well, are seeing infections about half the time. And that's, again, a lot of infection. And what I won't show you here, but is reported in this paper, is about 1/3 of the patients in urgent care and after hours general practice with infection are transported to hospital or kept in an observation unit. So people with infection out of hours need a lot of input. And I intuit from this that quite a lot of quite serious infectious diseases are managed in primary care. And of course, I don't work in primary care, so I can't verify that by experience. But I think we all know it to be true. And that data tells us that. So the next question is, what are primary care doctors using to recognize sepsis? What gestalt or what kind of factors are important in triggering referrals from primary care to hospital? And this is a study from the Netherlands, and they asked a sample of general practitioners to say, for these people that you referred to hospital, what were the factors that made you refer, which is transfer from your clinic to a hospital for assessment? And the results speak to people being worried by the way people look. So general appearance, gut feeling, something I got from the history, a little bit less from physical examination, but you get the sense that people are relying on their gut feeling to spot people who are ill. And what else? The other elements of this are being unable to stand, makes sense. Rapid progression, and then other things dropping off. So dyspnea, rigering, 70% of people said that was important to their referral. And basically I come back to this slide to say that really people are saying that I thought this person looked really sick and I referred them. So interestingly, the key findings in their examinations which prompted referral were quite sharp, and obviously findings which we would all take seriously. So low blood pressure, high respiratory rate, sweaty skin changes, fast heart rate, altered mental status. And I've highlighted these to you because these are all in the tools that we and others have developed to try and assist decision-making in primary care. I'll talk to them a little bit in a minute. So is there a troponin for sepsis? So amongst all of this data about how people behave and what people use to trigger referrals of patients with infection from primary care to hospital, is there a cardiac troponin that you can magically do on a prick of the finger to refer to hospital? And the answer there is no. The biomarker procalcitonin lactate CRP literature is riddled with disappointments and basically appears to be to offer no help to clinical decision makers in the community. This one study which I dug out to talk for this talk, there were no patients who were reclassified as having sepsis based on the results of a biomarker assay. And so all of this work is being done by the good clinical work of clinicians. So sepsis is, I wouldn't say uniquely, but it really relies on clinical acumen and suspicion and judgment for diagnosis. There is no single biomarker that you can use. So I knew that at some point in this talk I would get dry in the mouth, and I'd wonder if you're all listening. So I thought I might just change the pace a little bit and talk a little bit about rigors and recognition and concern. And the best way to do that is to share a story with you. And I will do that by going to a video. So give me a second. This is from the Trust website, but this is a gentleman called Reece and his mum. His mum's a teacher, and she's a good friend of one of our nurse practitioners in the HDU and ICU, who we'll speak to a little bit later on. Reece presented via an urgent care centre in Hamilton with appendicitis and had a bit of kidney injury and a saggy blood pressure along the way. And this is his story. His whānau wanted to share their story with them because of the stress around the initial presentation and transfer to hospital. So it's a good case to reflect on for people who work where we work. And so I'll play it from 1 minute 20, where Reece is talking about what it felt like to have a rigor.
You know, starting to get quite a bad fever, and yeah, gave me a blanket, and I started getting this feeling like I was tensing up, and I just started shaking uncontrollably. I didn't actually know what was going on, you know.
Initial diagnosis, UTI, they gave him a shot with pain relief, shot with antibiotics, sent us home on oral antibiotics. I knew there was something not right, so I texted friends who was working in the medical profession just to let her know, and she had said to me, ask the next clinician that walks into the room, could this be sepsis?
So that's Reece's mum got in touch with Elaine, and this is Elaine's side of the story.
Hi, I'm Elaine. I'm a nurse practitioner at Waikato Hospital. I was initially contacted by Maureen, who's a family friend, because Reece was really unwell. And when I did get my message, when I did look at my messages, she said to me he was really unwell, had become unwell over the last 24 hours. Her red light statements were, he doesn't want to get off the couch, he doesn't care what I'm doing, he doesn't care what I do, and she was taking him to the emergency department at the A&E. She then called back to say to me they diagnosed him as having a UTI. This is a 17-year-old, and something didn't ring right with me, so I called Maureen and couldn't get in touch with her. And so I sent her a text message that said, please ask the next clinician that comes in to review Reece. And I put it in inverted commas saying, could this be sepsis?
Thank you, Elaine. So there's quite a lot to cover in that story, and what I really, looking at it again, you can we've all got relatively high EQs. So knowing Elaine and Maureen and having met Reece, it's actually quite affecting to see them remembering how stressful and worried they were. And other than your individual intuitions about the clinical case in front of you, we definitely emphasize the importance of loss of function and relatives' concern in recognizing sepsis, because in the very early stages, it's probably true for all acute illness, the family and whānau really recognize that something's amiss. And it's that ability to stop and check and ask, could it be sepsis, which I think protects, is a good protection against missing what can ultimately be a condition with a poor outcome. So what is the importance of true rigoring in adults? So I'm bringing this up because it's really helped me, and you know, obviously we're all learning things over a career, but I never really grasped this about rigors until I came across a Twitter tutorial by a guy called Tony Brew, who's still worth following, even though Twitter's become X and looks like a bit of a mess. But I have actually learned something from Twitter. So what is rigoring? Well, it comes up in things that you shouldn't discharge from the emergency department and things which you should keep a close eye on. And people will often come to acute medicine saying, I had a horrible shake about 2 hours ago, and they can look relatively well. Maybe a bit of tachycardia, maybe a bit sweaty, but the shaking happened in the past. And if you recognize that the shaking's happened, here's what you can tell. So the reason that rigoring happened, well, what is rigoring, first of all? So rigoring is involuntary muscle activity to raise the body temperature. That's what the human body is trying to do when it is shaking uncontrollably in response to infection. And the process is that a bacterium or a flagellum or a fragment of the bacteria is interacting with receptors in the brainstem, which recognize that there is a pathogen or a poison in the blood. And the brainstem is trying to rapidly raise the body temperature so that the marginated white cells in the bone marrow and circulation demarginate and migrate to tissue, which very rapidly increases the total number of activated phagocytic cells, which are looking for bacteria and infection in tissues. So let me go over that again. So what does it feel like? So people say, I felt a horrible chill. Usually rigoring is preceded by a feeling of cold. And that's the brainstem saying, I need you to seek heat. I need this body to be warmer. The chill is very quickly followed by involuntary muscle activity, which lasts anywhere from 1 to several minutes. And of course, if your body temperature gets up to about 38, 39 degrees, it has to come down again. So how does that happen? People sweat. So a true rigor is involuntary muscle activity preceded by a chill, followed by a sweat. And that's to get the body temperature up and then the body temperature down. The purpose of the rigor is to demarginate phagocytic cells, which migrate to tissue to phagocytose bacteria. And I haven't shown all the papers that I've got on this, but if you identify a rigor in somebody presenting with fever to an emergency department, they've got something between a 10 and a 40 times the chance of having a positive blood culture compared with people who've got fever and no rigoring. And so rigoring, I've come to think of it as the symptom which you have to take seriously and which necessitates some kind of second look or referral to hospital. Funnily enough, that was true in the late 90s when I started working in the emergency department. I had a consultant called Willie Tullett, who said, we never discharge people with a persistent sinus tachycardia, and we never discharge people who've rigored. And so I think that, that this importance of rigoring was intuited by senior clinicians for a long time. So in the end, to try and distill knowledge and wisdom into something that's usable, you have to generate a clinical tool. So what I'm moving to now is talking to you about how the TRUST tool can be used to diagnose red flags or red flag sepsis, which prompting a referral to hospital. So you can find this on sepsis.org.nz under clinical tools. The clinical tools are separated into pre-hospital and acute care or hospital-based tools, and into pediatric, maternal, and adult tools. So if you go to the website and have a look after this, you'll see that there's usable tools right there for you. So if you're thinking, could this be sepsis, dig out the tool, pick the right context and the right patient group, and then have a look. And what you can see is, what you will see is that the tools are all organized in the same general way. In the top left-hand corner, there's the prompt to say, not only do they have an infection, but they look really sick, or a family member is concerned, or they seem to be deteriorating, or their physiology is abnormal. So those are the 4 prompts which we encourage people to think of as the positive to move on to the next box. All the important stuff's down the left-hand side. If box 1 is true and you confirm the presence of a red flag, and they're all listed there, hopefully you can see them, but for example, respiratory rate above 25, not passing urine, reduced level of consciousness, do not pass go, do not collect $200, call it red flag sepsis, and arrange transport to hospital. One of the things Bruce said when we were talking before this talk was to give tools to people, give language to people, give people the context for referral to hospital. And I would say that red flag sepsis is an inarguable referral to hospital for people who are eligible for resuscitation. If people satisfy the first box, you're worried, but they don't have a red flag, and bearing in mind that sepsis is a disease which can evolve over time, there's an amber flag box which gives you some important prompts to have a think. These are things which really signify that people probably are at increased risk of having sepsis. And in New Zealand and Aotearoa, I really want to draw attention to the inclusion of ethnicity as a risk for reasons I don't think I need to talk about anymore, but we have included that as a risk in the amber flag category for work in New Zealand. Why are red flags red flags? Well, they're not just picked out of thin air. They're based on large data sets which were used to develop the early warning score for use in hospitals. And they are individual measurements which by themselves signify a risk of in-hospital mortality of 10% or more. So if you get a red flag, you are looking at somebody who's at risk of death. Whether they seem to be just a bit okay or not, just do not pass go, do not collect $200. Believe your eyes. Red flags are red flags for a reason, and they're included there because there's an evidence base that justifies taking action. In the amber flag category, this is all about being a good clinician. You are free to do what you like based on clinical context and availability of treatment and follow-up. You can see them again in 24 hours. You can write a handover to a colleague who's on call in the evening. You can transfer them to hospital because you're worried. You can keep them in the clinic, give them an antibiotic and review them at the end of the clinic if you've got that opportunity. You can put them in your acute care area. But this is all about having a and stepping back and thinking, am I seeing something here in this amber flag group where I should really be worried? And at least in the hospital setting, what we're advising people to do is to speak to a senior clinician. And if you've got that opportunity to review and think, then that's a great way to approach these kind of slightly more uncertain cases. Here's the tool. And what I said is about the tool is true. All the action happens to the left-hand side of the tool. If you see a red flag, pick up the phone and refer that patient to hospital. If you say that you suspect sepsis with red flags, that should be enough to get a referral across the line. Don't worry about not knowing what the infection is. In my hospital, people leave the emergency department with a diagnosis of sepsis without knowing what the cause is about 1 time in 5. So it's really, really common. It often takes a day or 2 in hospital to work out why people have presented. And so there's certainly no whakama around not knowing what the infection is. If you've got somebody who's ill, red flags, refer. So resources. So we're quite proud of the website. It's taken a while to get it together and get it looking good. I use this in my practice all the time, so hopefully that's a signal that this is usable. So there's 2 groups here that I want that you have resources for. So there's the group of people who are at risk of sepsis. They should be pointed to the Te Reo Pākehā or the Te Reo Māori leaflet or resources about what sepsis is and what it looks like. This is all laid out here with a downloadable trifold leaflet, which you can distribute or share for safety netting purposes. And under the resources tab, this is for people who have had sepsis. And what we have developed here at the request of survivors is information about what we're doing at a national level to try and tackle this problem. Provided information about the post-sepsis recovery, what we might sometimes call the post-sepsis syndrome, and some information about what it can look like when people leave hospital. And the message here is we don't do a fantastic job in helping people to recover well from sepsis as hospital-based clinicians. And so there's some information in these leaflets about what you might see as you collect somebody on the other side of a sepsis event. So it's not what I'm talking about tonight, so I thought I'd just move on. And yeah, there's lots of work to do. Locally, you can advocate for sepsis as something that has a specific program of work. You might look at your own data. We're trying to set up conferences. We're looking for partners who want to look at this problem from multiple angles. The Sepsis Conference in 2021, mid-COVID, was a partnership with the Australasian Society of Infectious Diseases and a number of other organizations, and it was a really successful event. It was well attended, and we found there was lots and lots to talk about. So sepsis is an infection is actually a really engaging topic for continuing education. ACC have done some work and funded some work in this area. There is the skeleton of a proposed national action plan. The good news is that it exists. The bad news is we're about 6 years behind Australia. And but we are getting there. We're starting to see some of these documents appear, which the trust has had some input into. And this is a stock take of sepsis management in New Zealand hospitals. And the message is there is no consistent approach to sepsis in New Zealand hospitals, which is something we're trying to do something about. And lots of people are interested in this around the world. So we took our lead from the UK Sepsis Trust. The WHO has dedicated funding to prevention of sepsis. There are a number of other advocacy organizations around the world, so plenty of resources should you want to look at them. So in summary, sepsis is a syndrome of acute on chronic endothelial failure caused by infection, characterized by inflammation and severe systemic illness, which should be regarded as an emergency and treated as such in acute healthcare settings. And these are the most important partnerships. These are people who we've worked with who have recovered from sepsis. And it's, I guess, sounds a little bit affected, but we're dedicating this work to them. They provide a lot of feedback and input into the work that we do. And that relationship building and that work with people who've gone through this illness has actually been one of the most satisfying and productive parts of what we've been doing. And yeah, that's where I think I'm going to stop.
Okay, Paul. There was one question there about the use of vitamin C in severe sepsis.
Yeah.
Do you have a view about that?
I do, and I'm smiling like a Cheshire cat because I've just recently diagnosed 2 patients with scurvy, and it might be worth going through some of the detail on that. We've had somebody in intensive care, by way of explaining just how awful these can be, that we've had somebody who's in his 50s and works in a sales job who's been in hospital for 85 days in intensive care with Staph aureus, sepsis and epidural abscess. And he was shocked at the beginning, and we sort of thought we were kind of winning. And around about day 23, 24, he became hemodynamically unstable. He started to develop a rash. He started to bleed from a biopsy site and his soft palate, and became hypotensive and unconscious. And there were a few things going on, but out of that came this question about why is he bleeding? And there is a lot of work on vitamin C and sepsis. And I thought, gosh, maybe this is somebody to check a vitamin C level in, and it was undetectable. And based on that case, he subsequently went on to almost die from a cardiac tamponade, which is due to vitamin C deficiency. It's a known complication. We went on and checked it at random in somebody who was just weak and failing to thrive and just feeling awful after a sepsis admission. And lo and behold, it was undetectable. So I think because of the background to vitamin C, some of us feel quite skeptical about it. There was, Linus Pauling became a fanatic and insisted that mega doses of vitamin C would cure everything. I think that those kind of approaches to anything in healthcare turn people off a little bit. But if you look at the biology of vitamin C, it certainly has a role in very important things like free radical scavenging, noradrenaline production, tissue healing, white cell function, lactate metabolism. It really is extremely important, and it's clearly depleted in sepsis. So it would seem obvious as a target to replace in intensive care. Unfortunately, the trials are not as promising as the observational data suggested. As so often happens in medicine, you get somebody with 4 or 5 very promising cases that they publish, and a whole lot of work and chatter follows. Unfortunately, vitamin C is at the doses of about 3 grams a day for the first 4 days of a sepsis admission has been shown to be equivalent to no care, and there's one study which showed harm. So no, vitamin C doesn't have an acute place in the management of sepsis at the moment. But what I'm interested in is actually the other side of it. About 20% of the population are either very deficient of vitamin C or actually have scurvy, defined as a level below 11. That's data that's been published by Anitra Carr out of Christchurch, Canterbury, Otago University. And I don't think it's bad medicine to give people vitamin C who've recovering from sepsis, because you will have at least 1 in 10 chance of treating scurvy, probably. And they might feel quite a lot better. They'll certainly thank you for prescribing something. And there's some logic to providing it. But at the moment, what we can't do is actually promise you that that will have a significant benefit to them in terms of long-term recovery and symptoms.
What's causing the scurvy? Is it part of the infectious process, or are they just a bit low on vitamin C when they come in?
That's a really good question. And actually, it comes. Me and a colleague were talking about this the other day. We've kind of accepted that deprivation, ethnicity, morbidity, all of these things predisposed to sepsis, but I'm not sure we totally understand why. I've suggested that it's long-term endothelial function, but a high proportion of those risk groups would have deficiencies of vitamin C, and in the acute phase, that vitamin C tissue store of vitamin C is rapidly depleted. So what I think might be happening, and it's a hypothesis that needs to be tested, is that people who don't have a lot of vitamin C, either in their tissues or in their diet, have sepsis, and then go back to the diet that they previously had, which is either short of or completely lacking vitamin C, and therefore never replace their vitamin C. So I think that the vitamin C story is not completely told. What I can tell you is it's not an acute, 3-day course of vitamin C will save, 10%, will reduce mortality by 10 or 15%. That's not what's happening in the randomized trials.
Would you suggest IV vitamin C or just the sort of the various oral forms?
I looked into this. So the most you can prescribe on a free prescription is 250 milligrams as a single dose per day. That's entirely safe and will not do any harm. The Health-Reece product, anything 500 milligrams or above in the Health-Reece line, which is where most people prescribe for high-dose vitamin C, is available at 500 milligrams or a gram. It would be clinically reasonable to prescribe a gram or 2 a day in someone who you knew to be vitamin C deficient, who had scurvy. But I spoke to Anitra Carr about this yesterday, and she said that the 250 milligram dose given long enough to a stable patient will eventually replete their vitamin C stores and will be free.
Is that IV or oral?
Oral, yeah. So to rapidly replace vitamin C levels in somebody with clinical scurvy, you need to give grams per day. And the only way we can do that in hospitals is to give Pabrinex, or the vitamin C preparations, IV. But in people who've recovered, who don't have clinical scurvy, who are hemodynamically stable, don't have major cardiac presentations, or Wernicke's encephalopathy, I would just give them, a multivite and 250 milligrams of vitamin C a day for a month, and they will eventually replete their vitamin C stores.
A question here: is the sepsis bundle still a thing? I don't know what the sepsis bundle is. 40% of my region is rural. Nobody will get to a hospital quickly. They may also be the case in Auckland, who are looking for the management direction in the community.
So the UK Sepsis Trust have published a separate tool for almost every individual clinical environment and setting you can imagine, and we felt that was too confusing. So we tried to consolidate the tools into pre-hospital and community tools, and in-hospital and urgent care. And we did that based on local feedback from colleagues in general practice about capabilities. So that again, I don't work in primary care, but what we were told, or what I understood, was that there are practices which have got little capability in terms of fluids, antibiotics and lactates and all the rest. And then there are some practices which have got some urgent care capability, mainly in more regional parts, or at one remove, I guess, from an ED. So the one I think of is Te Awamutu Medical Centre, which has got 2 acute care beds because the transport time to hospital can be an hour or longer. And then there's the true urgent care, and there's the emergency departments. So I recognize that we all work across slightly different settings in terms of capability. So all I really ask you to do is to choose the tool that works for your setting or the role that you're in on any given day. The pre-hospital tools do not have the bundle because the assumption is that you don't have any capability and you're going to get help for that patient by calling an ambulance. The urgent care tools, and I'll download the adult one because that's the one I'm most familiar with, have a second page which does have all the bundle steps. So if you're working in urgent care and you've got the capability to, we'll call it stay and play, or give the fluids, give the antibiotics, check the lactate if you've got it, give some oxygen if you've got it, then go for it. Absolutely, go crazy. But that's the way that the tools are laid out. So I think that answers the question.
If you can't get IV access, if somebody's very shut down, is it okay to give IM antibiotics?
Yes, it is. Most people carry ceftriaxone, and that would be fine given intramuscularly. We cover about probably 80 to 90% of major community pathogens. Yeah, you still need to follow up, but the ambulances will give augmentin and gentamicin as a protocol. And I haven't really explored this, but I think that if you've the chance to interact with an ambulance crew and you're really worried and you haven't given antibiotics, you can stipulate that you think this person has red flag sepsis and you want them to have antibiotics in the ambulance. If it's a paramedic crew, they will do that if you point out the red flags.
Should vitamin C test be done to determine sepsis? Is that no? Okay. What's the values of coag, VGB, lactate to consider sepsis?
Actually, remarkably little, unless someone's got clinical disseminated intravascular coagulation. So we normally check coags if people are thrombocytopenic or bleeding, but not routinely. On the lactate side of things, quite a complicated one. That was said to be the troponin for sepsis. It clearly isn't. It's got prognostic value. So mortality for any value above 2, and it's basically diagnosis shock with any value of 4 or above. And it's a marker of adrenergic stimulation because it's overloads the cell with pyruvate, which gets converted to lactate. There's this idea that people have got no blood flowing to their muscles, so therefore the lactate builds up. That's not what's happening. It's much more complicated than that. I don't know all the physiology, but it comes down to alpha adrenergic stimulation rapidly increasing the amount of pyruvate in the cell, and excess pyruvate that can't be turned into ATP, I think, gets shuttled across to lactate for energy, and that's where the lactate's probably coming from. So it's a marker of somebody under extreme stress. Is in my mind. So that lactate, it's a part of your checking for prognosis and to diagnose shock if you've got a lactate machine with you.
Probably not a good primary care example. Intraosselar antibiotics, sticking them in, presumably is that in the tibia that you do that?
I know nothing about that, actually. I think my understanding is you can give everything into an intraosselar osseous cannula that you can give into a vein.
Yep. So if you're desperate, but I guess IM's the other option, isn't it?
Yep.
Should every patient with a rigor be sent to hospital if they have a reasonable history for influenza and all OBS are normal?
I would put that in the amber flag basket. I think it would be right to be very, very alert to the possibility that something else is going on if someone's had a true rigor. I'm just conscious of that. There's always, I think hospital medicine is very much about the rear view mirror. Oh, now we realize the rigor was the E. coli bacteremia from the undiagnosed liver abscess. I think of rigors as being much more associated with bacterial infections than viral infections, and I'm going to include flu in that. But if it's only a shaking chill and you've got a completely normal person with a plausible alternative diagnosis in front of you, that's an amber flag situation. I would safety net, treat as you see necessary, and make sure they have some information about how to respond if they become worse.
Because the very sick influenza patient can look like a sepsis, can't it? Although the impression I've got is they've got respiratory symptoms that would rule down sepsis if all else was equal. Or did you get the hypotension tachycardia with severe influenza?
Well, what you get with influenza is superimposed bacterial infection. So if you have some, and I talked to Bruce about this beforehand, but there's the reason sepsis is so difficult and it might be worth talking about this now, in primary care, is that there is a tipping point, and there are second infections on top of the initiating infection. So actually respiratory infections are a really good example of that. So we've got a lady in hospital in ICU at the moment, comes to mind, who had an RSV infection, who developed pneumococcal sinusitis, mastoiditis, and meningitis. And the sequence of events is very definitely viral infection, rigors, sepsis, shock, meningitis, ICU. And the prodrome was about 2 days long, and the time from confusion, rigor, so then there was a rigor, and about 4 hours later there was confusion, hypotension, purpura, near death. And so, and not all cases are that dramatic, but many people have got some kind of recognizable way in, and then a tipping point. And I think that I agreed with Bruce before that the great fear and the difficulty in primary care is probably that you're seeing people before the tipping point. They'll often have some clues. I think a rigor in the right context is a clue that something's not right. But even in somebody who you believe has flu, it's not a red flag, because it's not a powerful enough prognosticator to be used as an automatic refer to hospital. But I think a history of rigoring with a few other flags, I would certainly worry.
So one of the issues about blood pressure, the med student who died, his blood pressure was 100/60, but there are some slim young women whose blood pressure is 95/60. Normally, they walk around with that.
Yeah, that's right.
But,
and
that in a big male is hypotension, isn't it?
Well, it's either not out and out hypotension and it's dropping, which is why it's in the amber flag criteria, or it's we didn't include this because it's too confusing, but to put in a tool. But if somebody's blood pressure is more than 50 systolic below their normal, that's an indicator of hypotension, regardless of the systolic blood pressure. So that's a particular trap in the elderly. So if you're dealing with someone you know has high blood pressure, they always come to clinic with a systolic of 160, and they've got a blood pressure of 105. That's not reassuring.
Over the years, is sepsis increasing in our society?
We'll probably have a publication on that by the end of next year, because that's planned work. The rates of hospitalization with infection have been increasing since the 80s, and that's by quite a lot, and proportionally, and that's in the Lancet. That was Michael Baker's publication about 12 years ago now. I think infectious diseases are back. I think we thought we dealt with them with penicillins, but I just don't think we have.
Could it just be that some of them are self-limiting, but we're hospitalizing more?
That's not the impression you get on our ward rounds. We're seeing quite sick people. We genuinely think we're seeing more infection, but it's hard to tie it down, and we need a national study to be sure of it.
Anyway, we're getting lots of lovely thank yous there, Paul. So you've been hugely appreciated tonight. And
thanks, guys.
I guess we doubly appreciate the fact you've set up the Sepsis Foundation. So we look forward to seeing more of you. So thank you very much. Over and out from us.
Happy to come anytime. Thanks, guys.